Good morning, and thank you for joining us today. Today's presentation is the last of 4 lectures addressing health disparities. Health disparities is under the umbrella of the Healthy Aging series. This series is a collaboration between OLLI, the University of Michigan Department of Geriatrics, the University Silver Club, the Turner African American Services Council, the Turner Senior Wellness Program, the Silver Club, the University of Michigan Institute for Healthcare Policy and Innovation, and the National Poll on Healthy Aging. My name is Edna Jackson Gray. I am a volunteer with the Turner African American Service Council and OLLI, and it is my pleasure to moderate today's program. The topic of the lecture today is community-based interventions to enhance lifespan equality. And our presenter for today is Dr. Philip Levy. We're very fortunate and quite happy to have Dr. Levy today. He is the Edward S. Thomas Endowed Professor for Emergency Medicine at the Wayne State University. He is the Assistant Vice President for Translational Science and Clinical Research Innovation. In addition to that, he is the Chief Innovation Officer for Wayne State University physician group, rather. Dr. Levy wears several hats. We will go a little bit further into his introduction a bit later, but for right now, we want to offer some tidbits on the Zoom presentation software that we're using. Immediately after following Dr. Levy's lecture, we will have an opportunity for a question and answer session. If you wish to submit a question, please click on your Q&A icon. Depending on, and it is the Q&A icon, not the chat. So depending on your device, the icon will be at the immediate top or the immediate bottom of your device, of your viewing window. If you experience any type of difficulties, such as a frozen window, something like that, the best solution is to exit out and then re-enter. If you continue to experience technical difficulties, please give a call to the Turner office, and that number is 734-998-9353. 734-998-9353. And back to Dr. Levy. Dr. Levy is a leading cardiovascular disease researcher. He has over 110 studies sponsored by different agencies such as CDC, NIH, American Health Association, and the Robert Wood Johnson Foundation. Currently, Dr. Levy his research is expanding, and his latest, starting in 2021, he has been sponsored by the National Institute on Minority Health and Human Disparities and the Association of American Heart and Heart Equity Research Network. Dr. Levy, I know you have a lot to tell us, so we're going to get into it. The virtual stage and audience is yours. Again, welcome.
Thank you, Edna, and thank you, Jennifer. It's my pleasure to be here with you guys today and our audience as well. We'll spend the next hour or so walking through an understanding of lifespan equality and delve into some of the work that you just alluded to, Edna. My slides will be available for anyone who wants them, and I know this session is being recorded, so you'll be able to review it later if that's of interest. So without further ado, I'm going to share screen here and get my presentation going. So hopefully everyone can see a picture right now of Alaska mountains, and that's off a plane in Denali. That's a screensaver I have in the background. Let's see if we can get this going. Okay, does that Everyone can see the title slide, community-based interventions to enhance lifespan equality. Edna, we're good from your end?
Yes, it is. Thank you.
All right, great. Great. So we're going to talk about, like I said, community-based interventions to enhance lifespan equality. Here are some of the grants that Edna mentioned. I have a significant amount of funding from various entities in the NIH and beyond. These entities support a lot of the work we're going to touch upon throughout this discussion, but none of this is industry-related support or anything like that. And so there's no real disclosures, or at least industry-relevant disclosures. So before we get going, I think it's really important that we level set on what terms are so that we understand what we're talking about. And we're going to touch on two things: life expectancy and lifespan equality. And life expectancy is a measure of the average lifespan of a population. So how long do people live in a given population? Lifespan equality is a measure of the variation in lifespan or age at death across populations. And they are not mutually exclusive necessarily, right? What we'll see is you often hear, terms about what is the life expectancy of a given nation, a given country. We'll walk through some of that. But really, the bigger question is, are there differences in lifespan equality across that nation, across other nations, that can be explainable and addressable such that everybody can live the same long duration and healthy life that we hope? And these terms are interrelated. And as it turns out, this is just a graphic to show that in the survival and longevity world, in the life expectancy research world, of which the Max Planck Institute in Germany spends a lot of time cogitating about, there's interest in understanding the relationship between these two things. So the idea that life expectancy and lifespan inequality or equality, if you think about it, do they interrelate? Well, as it turns out, they do. And what it seems is that when the life expectancy is lower, and these are 4 different measures of lifespan equality on the y-axis, life expectancy at birth is on the x-axis. And these data are derived from multiple different data sources that have different populations included, just to get a sense of overall, are these consistent relationships? And what it turns out is that lifespan inequity or equality, if you want to think about it, is much more impactful when people tend to die younger. Right? That's just because there's greater variability. If the mean life expectancy in a population is only 50 or so, some people are going to live to the 80s and some people are going to die in the 40s. And that's why you get a bigger spread and you have not, complete equity, if you will, or equality in lifespan. And then as people start to live longer in a population, there's less variability because all boats rise, or at least that's the theory, right? So, when we talk about national averages of life expectancy in the United States versus other nations, we kind of presume that lifespan equality is relatively stable across areas, and that we can extrapolate, if you will, from a nation's lifespan, expectancy to every individual in that nation. And as we'll see here, that is probably not true. So if we start, though, looking at this as a macro concept from the United States to other nations, and we look at things that often come into this, right? Healthcare spending versus life expectancy. These data aren't surprising. I think everyone on here is at least aware to some degree that the United States has by far the highest spending per capita per person. These are in 2022 US dollars on healthcare, almost 11,000 per person versus the lowest in Italy of almost 1,100. And these are OECD countries, right? The Office of Economic Development, basically. These are, comparable countries with similar types of economies. The average is about 4,000, but when you look at life expectancy, well, Italy spends the least and they have the lowest life expectancy. If you guys have ever been to Italy, I'm sure people would say they live maybe the best life during those years, but that's not what we're here to talk about. But the United States, while spending the most, has a median life expectancy of just under 79 years, while Japan, which spends close to the average, people live almost, beyond 84 years. And so, why is that? Why might we have these differences in lifespan equality across nations as represented by differences in life expectancy? Why isn't everyone living to age 84 across all nations? Obviously, spending has a lot to do with it. And we delve into this in the United States. We know consistently since data over the last 40 years or so show that the United States overall spends more of the percentage of its GDP on healthcare than any other nation by far. far, right? The closest is Switzerland behind us at 11% or so. In this 2019 data, again, things haven't changed too much recently, but you can see this really started to diverge in the 80s, right? And interestingly, when you look at that divergence on the left over here in the 80s in terms of expenditures, where the US really started to take off in terms of expenditures and other countries had a little bit more stagnation in expenditures, we started to dip off in the life expectancy, which is a little bit strange, right? You know, why would a nation that's spending more money on healthcare than any other nation, and at a point when we started to spend more money, start to see diminishing returns in terms of outcomes for the population? I think if we delve in a little bit deeper, and this graphic here, these two graphics are taken from a New York Times article from 2018. The rest of the information comes from the Commonwealth Fund, and every year they publish data on healthcare expenditures and outcomes. And so if we look at healthcare system performance compared to spending, right, you see higher healthcare system performance on the left, on the y-axis versus lower, and then healthcare spending on the x-axis. And you can see there's a clustering of other OECD nations kind of around the median right there, you know, plus minus a little bit on either end in terms of healthcare system performance for relatively lower spending. But here we are, an outlier in the United States on, again, spending so much money, but having lower levels of health system performance. And if you look at specifically kind of changes over time in mortality, this is a decade between 2019 and 2009, you can see that avoidable deaths and a 10-year reduction. You know, how well have we been doing at actually addressing things that are considered avoidable deaths, deaths that may be related to better upfront treatment, better prevention care, those types of things. You can see that most nations that we would compare ourselves to with lower spending have dramatic improvements in avoidable mortality over time. The top, is where mortality started in 2009, excuse me, and the bottom here is where it was in 2019. And you can see differences, that uniformly are at least better than 10% and closer to 20% over time. Again, the US is an outlier here. We've only had a 5% reduction in the last decade or so in avoidable deaths. So naturally, it might make sense that if we have all these avoidable deaths and we're not doing anything about it, we're going to see higher mortality in our country despite spending more money. I mean, again, it's a conundrum. Why are we spending so much money and not really able to move the needle on this? And the other piece of this too is that despite spending all of this money, our system is low performing in terms of affordability, right? So compared to the UK, which has, their national health system, and other European countries which do a better job, if you will, in terms of paying for healthcare for everybody, you can see the US really, again, has lower performance in terms of affordability for healthcare. And people are much more likely in the US to report cost-related access problems to healthcare. So again, it's not really surprising we have worse outcomes, but it's very difficult to explain, why, despite spending all this money, that may be the case. And we're going to really kind of delve into this. And you can see here that when you have these differences in terms of affordability of healthcare, it disproportionately impacts the lower income population in the United States versus other countries, and compared to higher income folks. And here, almost 50% of people, these lighter green circles are lower income. Almost 50% of people in the US who are low income report access problems. And obviously that, affects healthcare quality. 27% of people in higher income still report the same type of thing, affordability access problems, but again, much higher than what you're seeing in other countries, especially for the low income populations. And this is really important because we know that low income or income itself is directly tied to life expectancy. So these data published in 2016 haven't really changed all too much. And these are data from across the United States looking at expected age at death for 40-year-olds. And that's often used as sort of a metric. You might see life expectancy from birth, you might see life expectancy from some sort of median number in age like 40. But what we see consistently is that for men and women, household income percentile has a huge impact in terms of longevity, right? And so if you look at the median household income here, which corresponds to the 20th, 40th, 60th, 80th, and 100th percentile in our nation at that time in 2016, right, that the bottom percentile, 20% or low, where the median income is 24 to 26,000, depending on men or women that you're looking at, there's a huge difference, almost a 5 or 6 year difference in life expectancy that narrows over time between men and women, right? and it does improve over time, particularly as there's more wealth in a family and a population, however you want to think about it. So there's a direct tie between income and life expectancy, and we know that the United States versus other countries has bigger challenges with poverty, shockingly, right? Despite being the wealthiest nation on the planet, bigger challenges with poverty than other countries, which might explain some of these distinctions. But interestingly enough, when you look at the map of the United States and you look at life expectancy, and on the top here, you see life expectancy for men versus women in low income quartiles versus high income quartiles. So the top is men on the left, women on the right for low income. The bottom is men on the left, women on the right for higher income. You can see that first and foremost, again, same type of thing. Low income people tend to die younger than higher income people, but there's huge variability across the country. If you look where we are here in Michigan, you can see around Southeast Michigan, the Detroit area extending up into the thumb, median life expectancy is less than 75 years, right? And if you go a little bit further on the west side of the state, you see, and that's for low-income folks, you see almost a 4-year difference, even in the same income population. So clearly something else is going on. Income can't be the sole variable, right? That's predicting these outcomes, but it's certainly an important one. And you see the same type of trend if you look at higher income, and again, focusing on men on the left side here, but you see the same trends for women on the right side. You could see that the median life expectancy in Detroit and Southeast Michigan, even for higher income folks, is still lower than other areas around the country. And so clearly we have something going on here that makes income important, but it's not the sole variable that really helps us understand, why, mortality rates may differ across community, why lifespan equality is different across communities. And it's important to think about it this way as well. It's not just, the differences in sort of the income of a population, it's who falls into these differences and different categories. So if you look here, this is a city by city comparison to show that, if you start out in low income and move up towards higher income, or if you look at low income versus higher income populations in New York versus San Francisco versus Dallas versus Detroit, you see this convergence again for men and women in terms of outcomes and life expectancy at the higher end of the income spectrum, and much more divergence in the lower income spectrum, with Detroit doing far worse than Dallas, San Francisco, or New York. And so, both for men and women. And so really to understand this, a key feature is understanding how many people fall into this bin. Right? We know Detroit, Southeast Michigan, to some degree, suffers disproportionately from low income and socioeconomic challenges. And so really what's going to help determine more than anything the life expectancy in a given community is how many people fall into the income-based category, because that will help determine how weighted, if you will, or how much of an impact that lower income population has on the overall outcomes of a given population, for a given region. And, when these researchers looked into it and they tried to understand, well, does socioeconomic factors, health behaviors, access to care, those types of things, do they impact outcomes? And again, comparing low income and local area characteristics versus high income and local area characteristics, we see a couple of areas of consistency and some areas of question, right? And so first and foremost, health behaviors, no matter who you are, higher or lower income, dramatically impact life expectancy. If you smoke, if you're obese, and if you don't exercise, or taking the corollary, the converse, if you do exercise, right, you have different outcomes. People who exercise tend to live longer. People who smoke and are obese or don't exercise, taking the inverse of this, tend to live shorter lives. And that's consistent, for low and high income folks, although the impact may be a little bit greater for smoking and obesity amongst lower income populations. You also see things like index for social capital and other measures of socioeconomic inequality may play into this, but this social capital is a really important one. How much do people have control over their environment and what gets done to them in the communities that they live? Clearly, a low index for social capital is important, especially in low income populations, whereas a high index for social capital matters more, obviously, in the top income populations, people who are more able to change their environment, manipulate things in their community, what have you, may be more likely to live longer lives. Some of this was researched years ago. You guys might be aware of the Whitehall Project in the UK. I don't have slides up here on this, but the Whitehall Project basically looked at income and its relationship to your position in work. So not just what you make, but how much capital do you have, social capital do you have, if you will, within your employment situation. And despite lower income, people who were at higher levels of leadership within an organization were more likely to have longer life expectancy. And so that social capital really plays an important part, but obviously interacts with other things. And then if you look further down, there are factors like median home value, local government expenditures, population density, proportion of college graduates. All of these things dramatically impact and increase the likelihood of better outcomes for low-income folks, but not so much in the higher income population. A little surprising, greater proportions of immigrants in high-income communities correspond to lower, lesser years of life expectancy, which, there's lots of reasons we might be able to think why that's so. Higher proportion of college graduates makes a positive impact, but other things don't. And it may be because there's not enough spread in those populations, right? The median home value in a higher income community is much likelier to be higher. So maybe it doesn't have as much of an impact because everyone lives in an area, where they're more likely to have higher home values. Likewise, interestingly, Black adults, or the proportion of Black adults in the population, is associated with lower life expectancies in the upper income quartiles, but not in the lower income quartiles. And that, again, may be something related to how Black populations develop disease and what happens to them that may be income dependent. But it also could be because there's not as many folks who fall into the high income category who are Black adults versus not as much spread, again, in the lower income populations, unfortunately, right? That the Black community tends to be plagued by lower socioeconomic status. And so if you have more folks who are Black who fall into the lower income category, it's going to be harder to show that that is impactful on health outcomes. But the bottom line of all of this, yes.
I'm so sorry to interrupt. We're having a number of comments coming in. People are having a tough time seeing the slides. So there's one person who can't see them at all. I can see them perfectly fine, but and I put in a little coaching message out. This is Jennifer Howard, by the way. I'm just interrupting your conversation. For the folks at home, please try taking your cursor and hovering it between the slide and Dr. Levy. There should be a bar that comes up. You should be able to drag that bar to the right. That should enlarge the size of the slides and minimize the size of Dr. Levy, so you can make the slides as big as you need them to be. Dr. Levy, I would say, even though I can see them perfectly fine, could we try unsharing your screen and then going back in just as a reset, just in case there's any issues there? And then I think we can move forward and we'll be in good shape.
Yeah, absolutely.
Yeah, so sorry to interrupt.
No worries.
Make sure that folks are able to see your slides clearly. There's a lot of good information there.
All right. And then, as we said, Jennifer, if you want, I don't know if you have a listserv, but if you want to send that link I sent you to everybody, if they can't see the slides, I can let everyone know what slides are on. And if they want to advance at home, they're more than welcome.
Absolutely. I'll go ahead and send that email in the background. So folks should get that. You should all get that in your email boxes shortly as well. All right.
So you guys,
so much.
No problems. You guys should all be seeing Alaska again. And now we'll move the slides up to that spot. Okay. And I'm going to advance to where we were. For those of you that have the slides at home and are going to open them up, this is slide 16, which is Forrester plots of Pearson correlation coefficients for low and high income with the reference of Chetty et al. From JAMA in 2016 on the bottom right. So hopefully you guys can see that. Please, again, feel free to stop if you can't see it. We have enough time on the back end, so we can carry beyond noon if we need to. So Jennifer, if you're cool, I'm going to continue on. Is that all right?
Yes, please. Thank you. And again, for those at home, look in your email boxes in a few moments, and I'll make sure that the slides are there so you can follow along there.
So to continue where we were, right, basically what these two comparisons show is that even though we can look across populations for a number of different factors, right, it's not always an apples to apples comparison in populations, because even though one thing may be more or less impactful in an economic subgroup, there could be differences in composition of those groups, which make it less likely that certain factors will be impactful. And so it's an important thing to understand as we look at these types of information. Likewise, another important thing to understand is that even though we've seen trends over time, right, mortality, the age of mortality tends to increase over time because we have better health care, we have better understanding, of healthful behaviors, we have policies that change over time to protect populations from potential harmful exposures. We see that what really also matters, again, is where people fall into bins of economics, because even though we see trends over time from 2000, again, this is men on the left, women on the right, trends over time from 2000 up to 2015 that show increases and annual change over time in the age at death amongst different income groups, that change over time is not equal, right? So the change over time is much lower amongst the low income population and much higher amongst the high income population. So said another way, people who have more wealth are more likely to live longer over time, not just at a single point in time. So what's really important to know, and again, this holds the same for men and women, although the slope is a little bit greater for women, and women overall tend to live longer, which I think we all know. But if you look at this, what really matters then is how often do people move from one category to another in a given community. So this idea, not just of income, but of social mobility, right? How easily do people move from category A to category B? How do they go from low income to, moderate or high income status? Well, what this basically shows, again, comparing men and women, this time women on the left versus men on the right, is that in the richest income quartile and the poorest income quartile, a rise in social mobility is important, but it may be even more important in those who start out with lower income, because they're already disadvantaged from the start. And if they can move from this line here up to this line or this line, right, that is going to change dramatically their likelihood of living a longer and healthier life. So, those factors are really important to consider. But then stepping away from all of this, we have to understand within the context of disease, right? What do communities get affected by? How does all of this information on socioeconomics play into life expectancy? Because it's not like, if you have lower socioeconomic status, that alone, that single factor alone is going to, make the difference. It impacts biology, and it's the biology and the interaction between biology and the environment that really produces the risk that we're talking about. So instead of just looking at economics and saying, well, poor people are doomed, right? That's not what we want to say. We want to really understand why that might be, and that can help us understand what either community-based interventions we can do to improve upon this, or beyond community-based interventions, what policy-based interventions might be needed. So I think a better way, or at least another way to look at this, is trying to understand what impacts different areas of our country most. And again, instead of just looking at life expectancy, trying to understand what people die of in different areas of our country, and then how can we think about using that as a way to target what we want to do to improve life expectancy in different communities. So this is a map that was created by Slate. I like it because it does a really nice job, not just showing the most common causes of death in the country, which we know by far are heart disease and cancer. Those are the two most common causes of death, not just in our country, but worldwide. But what we see is that when you look at a map of the United States, two states in particular are disproportionately impacted by heart disease itself: Michigan and Rhode Island. We're here in Michigan, so we're really going to focus on what impacts us here in Michigan, and then that will again tie into the interventions that we've been working on since before the pandemic, through the pandemic, and hopefully during the endemic phase of COVID going forward. So if we look at Michigan, disproportionately impacted, why might that be? Well, these are the top 10 causes of death, or at least a snapshot of the most interesting ones to me, from the top 10 causes. And what you see here, you can see things like stroke and diabetes, which get a lot of attention, kidney disease, in Detroit, especially unintentional injuries, but far and away, heart disease and cancer are the most important, at least, causes of death. And when you look here, heart disease so outshadows everything else, you can't help but be drawn to this, this bar chart on the left side, which shows that in the city of Detroit in orange, right, the age-adjusted mortality rate per 100,000 is almost 290. In Wayne County, it's less. In the state of Michigan, it's less. And compared to the national average, it's much greater, right? And what you see is the state of Michigan, Wayne County are all I wouldn't say dragged, that's probably not the right word, but they're being impacted by this way disproportionate age-adjusted mortality rate in the city of Detroit, which really says we have a problem with heart disease death. And if we want to look, why are more people dying, in Michigan and living less robust lives, if you will, look no further than heart disease death, right? This is what's explaining a lot of the difference in disparity. So in a way to think about what types of interventions we'd want to do, where would you want to put your money if you were going to invest in some type of intervention and solution? You'd put your money, if you will, into things that are going to reduce heart disease death and therefore give people, longer lives to live. And it's interesting when you age adjust mortality in Detroit, right? And the reason that we age adjust mortality is so that communities with a higher proportion of older individuals don't have a seemingly higher mortality rate, because the mortality rate itself is not necessarily higher. Overall, what it is that you have more older people who are more likely to die. So when you age adjust mortality, typically mortality rates go down. So what you're doing is figuring out the mortality rate for each age bracket, if you will, and then weighting and adjusting the overall mortality rate by the representativeness of those individuals in the population you're looking at. So, you go to places like Broward County in Florida and whatnot, and you age adjust mortality, and lo and behold, mortality rates go down. When you age adjust mortality, especially for heart disease in Detroit, it goes up. And it goes up because you have disproportionate representation of young people who are dying of heart disease. And so that is how you change life expectancy, right? You change that calibration. You find the folks who are dying younger, right, before they develop disease, and then you move forward with an intervention or a program or a plan to try to address that. Now, we know a couple of things about heart disease. Number one, that elevated blood pressure is the strongest modifiable risk factor for cardiovascular disease, heart disease worldwide. There is zero question about that. Certain communities are more disproportionately impacted by high blood pressure depending on the population that they have. If you take the city of Detroit, right, which is somewhere between 80, 85%, depending on the community that you look at, Black population, we know that the proportion or the prevalence of hypertension in the Black population is close to 60% versus about 40, 45% in the white population. And so you naturally have more people who are at risk for hypertension and develop hypertension. And we also know that hypertension control rates are much worse in the Black population. Again, that might clearly explain, or at least cognitively, push us in a direction to understand where we might want to target our efforts to improve lifespan equality in Michigan, in Detroit in particular. We also know things like controlling blood pressure is a huge public health intervention, right? So this was published a couple of years ago, but basically looks at what would be the impact if we controlled blood pressure, reduce blood pressure by 10 to 15 millimeters of mercury, increase the proportion of people with hypertension who are treated, reduce sodium intake by whatever percentage, because that also, impacts blood pressure and its likelihood of control. We could save 94 million lives, not tomorrow, but over 25 years, because what you're trying to do is intervene today for tomorrow's outcome, and that's what changes life expectancy. So clearly, investing the time and effort into better blood pressure control would be very impactful for cities like Detroit or other communities that mirror some of the same circumstances that Detroit has. And we also know a couple other things, right? That we can have very specific things we can target in a population if we want to understand, are we moving the needle? We can't wait 25 years to show that the interventions that we're doing have had outcome benefits, right? Even though we know it will, if we control blood pressure, it will be better. But one thing we do know is that if you lower blood pressure at the population level by as little as 2 millimeters of mercury, and that's not my blood pressure going down from 134 to 132, that's taking an entire community, entire zip code or census tract or city, however you want to conceptualize it, and lowering the average blood pressure by 2 millimeters of mercury. That means someone's going to drop by 20, someone's going to drop by 5, someone may go up by 4, but on the whole, if we lower blood pressure by 2 millimeters of mercury, we can prevent almost 25 to 30% of incident coronary heart disease events, a little bit less, but still high numbers for stroke, and up to 50% of incident heart failure. And the black circles indicate the Black population and the impact, while the white squares indicate the white population. And you can see this outsized benefit could accrue in the Black population by just lowering blood pressure 2 millimeters of mercury at the population level. And this has never been more timely because we've made great strides over the past 20 years or so, 15 years or so, in terms of getting blood pressure controlled among all adults with hypertension on the left and among those with hypertension who are taking antihypertensive medication, but nowhere near where we want to be, right? The best we've done in terms of control rates is 50% for those with hypertension overall, and almost 65% or 70% for those who are medicated, but it's not 100%. And what's more disturbing than that is it's starting to tail off in recent years. And we'll see in a couple of slides in this presentation that COVID is not a blessing on this. COVID is only going to make things worse. And so if we already have these trends, right, we really need to be thinking about how we can do things differently to address this greatest need amongst our population. And this has prompted the Surgeon General just about a year and a half ago to issue a call to action around controlling hypertension. Again, recognizing that it's such a critical risk factor for population health outcomes, and that it's getting worse in control. We have to all be thinking of this because, again, especially in communities like Detroit, it's this type of thing that is going to allow us to do interventions and target outreach that's going to improve lifespan equality for residents in the city of Detroit. And we know that certain things play into this, right? There's the medical side of what gets done. So this is a great publication from a couple of years ago by Ken Mukamal and his group. And what I like about this is not what I see on here, but what it represents, right? And it shows that over about a decade, a little bit under of a decade in the VA, which for anybody who's practiced in the VA, anyone who's a veteran, anybody who's gone to a VA, you know that the VA, while it has its share of problems, is a very well-managed closed system in the sense that nobody suffers because they can't get medications, right? Oftentimes there's a pharmacy right in the building where the provider can hit a number, hit an order, and the pharmacy, is ready with your prescription when, almost before you leave the office. Yet, when you look at all patients who present into clinics, patients on hypertension medications and patients not on hypertension medications who had a visit where hypertensive treatment intensification or initiation would have been justified by the numbers, you could see that very few of these encounters, especially more recently, was something done, right? Less than 10 to 20% of these encounters was actual, intensification of therapy done. And so this idea, at least of people who are on medications and this concept of therapeutic inertia, right? Where people aren't doing enough to move the needle forward is a real thing. And so efforts have been done to improve upon blood pressure control by thinking about team-based care and titration from non-physicians, especially pharmacists, right? Pharmacists, collaborative agreements, enhancing titration and agreed upon protocols for hypertension management are very effective, as are scheduled team-based titration events by physicians. But it's this type of top-level management that can produce significant improvements in blood pressure that has, come up as a bit of a focus area and of an interest area going forward. And perhaps the best example of a population-level impact that can happen is the Barbershop Trial that was done in Los Angeles by Ron Victor, obviously before he passed away a few years ago. And one of the key things about this that people tend to think about is that this was done in barbershops. But the other aspect of it is that all of this care was delivered under collaborative practice agreements with specialty trained pharmacists who did, drug therapy, titration, and intensification, not physicians. So physicians were out of the equation. And again, probably most of us have seen the numbers where there was almost a 20 millimeter of mercury difference amongst the population for those managed through the barbershops with the pharmacists versus people who referred back to their physicians. And so this idea of what can we do structurally from a care delivery perspective is obviously really important. Other studies have looked at how can we take information and improve medication therapy management, again, using pharmacists, using protocols. This information on about 5,000 people managed within the Beth Israel Deaconess system, which is affiliated with Harvard and Boston, looked at blood pressure control for a cohort of almost 1,400 people, and the standard approach with home monitoring and everything had a good impact on blood pressure control, good impact on cholesterol control. Sorry if this is an overwhelming slide, not intended to read every line, but just to show there are programs out there. But a lot of the programs that are out there focus so much time on the clinical aspect of it, they don't really incorporate the other things that may impact health outcomes, right? The things that may result from socioeconomic status and income that aren't always tied to things like medication accessibility, right? There are other factors to consider. In fact, we know that healthcare itself only contributes about 20% to health outcomes. So while access and quality of care are really important, things like health behaviors, which we saw already in our group by group comparison on income, matter a lot. Physical environment matters, socioeconomic factors matter. And so how do we rethink healthcare so that we're not just always focused on this 20% box down here, right? And that we can incorporate the other 80% of what we're trying to do into a systematic approach, community-based, with a focus on enhancing lifespan equality by intervening at early time points to prevent the things that are most impactful on a community. So, there's been some early work in this that's looked at it. And so if you take variation across the country in medication adherence, for example, right? You can look at this using structural equational modeling, and you can take in data from the CDC and look at areas across the country for medication adherence and where is it higher, where is it lower across the country. And you can incorporate certain social factors to get a sense of how impactful are social circumstances on medication adherence beyond what we're doing in the doctor's office. And so using structural equational modeling, these investigators included things like poverty, using readily available data points like percent below poverty line, uninsured, proportion with SNAP benefits, social support, which includes things like single parent households and racial segregation, the built environment, food insecurity. And you can combine these together to understand in a pathway analysis model, how do these things affect medication non-adherence, right? The antihypertensive medication non-adherence. And we could see things like poverty and food insecurity have a direct impact on medication adherence. Weak social support does as well. A healthy built environment has an inverse relationship. And, you can come up with some understanding and prediction of what things affect medication non-adherence. But when you look at the R squared on this, these factors only explain about 30% of overall medication non-adherence. So it's really not a fully explanatory model that's actionable. It says some things, right? But it doesn't tell us, in a given area, what's the most important thing impacting a population. It just gives us some macro level ideas, but it only explains 30% of the variance that we're seeing. So clearly not enough, right, to go out there and target or tailor a whole intervention plan around something like this, but things that are important. And so really what we need to do to understand life course dimensions and understand life course impacts is get a handle on what is the individual's external environment, right? How much physical activity do they do? Do they smoke? What is their diet? What are the general external environmental factors? Things like traffic and pollution and PM 2.5 exposure, social capital, as we saw, the urban environment, which we just saw, green spaces, climate, those things. How does that mix with the internal environment of the human themselves, right? What is their genetic predisposition? How does it interact with that to ultimately produce health risk and impact, how we might want to assess this individual and at what time point we might want to do that assessment. And so effectively what this is saying is that we really need to understand not just differences in life expectancy by income, but we need to think about things like this. How do we partition out these other factors so we understand in a given area what are the most impactful things that cause disproportionate death at a young age, right? And it's not the same everywhere. And that's a key point here, is that if we want to understand what community-based interventions are needed, we need to understand our communities themselves, right? And so if we want to impact the life course, right? So Detroit, other cities that have high heart disease death rates, right? They start to split the trajectory early on in early adulthood and middle age, and communities that don't address these risk factors like hypertension effectively have early vascular aging, and people die young of consequences of cardiovascular disease like strokes and heart attacks and what have you. Compared to the average life course in communities that don't have that same, impact, or they address them differently, clearly you could see, this change in trajectory, right? You don't want something so acute. You want something that's a little bit more obtuse or not as rapidly rising from a slope. So if we want to get to this ideal life course, what you clearly see in this graphic is that we have to start to think about this early adulthood and middle age point. That's how you enhance life expectancy and change lifespan equality, is by focusing not at the end of life, but early in life, before things have impacted the individual and while change is still possible. So we developed a program called Phoenix to try to understand all of this. This preceded COVID, preceded our grant work, but Phoenix was intended for us to understand what is the confluence of social factors, biological factors that help explain why community A versus community B has higher risk and potentially worse outcomes. We have published papers on this that kind of explain what the macro level concept is, but effectively what we're trying to do is look at various inputs: health data from EHR, social determinant data, community screening data, patient-generated data from cell phone apps, other pieces of information we can incorporate that we can tie together in a comprehensive way to understand where are hotspots in communities, target program intervention, and then evaluate benefits and changes over time, all passively. And so that's what we're going to focus on for the next part of the talk right here, is using a tool like this so that we can tailor and target outreach to communities with an eye towards the things that impact longevity and a goal of reducing the impact so that people can live longer lives. And this Phoenix project started with an alpha version, if you will, of data. My real interest where this started was trying to understand pressure load, if you will, on a community. So I showed you data that 2 millimeter of mercury reduction at the population level can produce or reduce up to 50% of the incident rate of heart failure in the Black population. How the heck do you ever get a community pressure? Right? How do we know that at a population level, we reduce pressure 2 millimeters of mercury? That's an incredibly hard thing to track. We took a concept from the HIV world, which is community viral load. Because of Ryan White funding, there's a lot of information on how well HIV is managed in populations, and communities that have low viral loads on average are communities where HIV is well managed. So we started to think about community pressure load. And we started incorporating data, I'm an ER doc, as I mentioned, from the emergency departments of the Henry Ford Health System and Detroit Medical Center. They have the bulk of the visits in the city of Detroit, and started to map these out, incorporating social factors that are available in the American Community Survey, just to get a sense of this pressure load concept so that we can have an idea maybe where we want to target and where we want to tailor outreach. And so this is the initial version of it, which includes blood pressures from the emergency department mapped out for almost 552,000 people across Southeast Michigan. And what we can see here, this community where I'm sitting right now, this census tract, this is where Wayne State and Detroit Medical Center, Detroit Receiving Hospital specifically, are located. And we can see that this represents 4,500 records almost, with a mean systolic blood pressure of 137, right? Quite high compared to national average. It also represents a population with a median age of 29, right? Which is really important because it says if we can do something here, we can make a big difference. But you see the social factors that go into this, right? In this community, median household income less than 14,000, 61% of families living below poverty, 35% unemployed, life expectancy at birth of 72 years, which is quite a bit younger than the national average, but only 12.5% uninsured. So it's not like these folks don't have potential accessibility of care resources. There's just other factors that are playing into this. And if you look at things like the Area Deprivation Index, which is a way to rank deprivation in communities, it's the worst that it can possibly be. So this area is set up, right, for failure, if you will. And if we don't think about how we get into communities like this to change this calibration, you're going to see a whole bunch of people who are 29 now dying in the next 20, 30 years from preventable heart disease because we haven't addressed the blood pressures that we're witnessing, right? And in the ER, it's one point, but right, it's much beyond that. It's out in the community. So whatever comes into the ER is broadly representative of the population from the neighborhoods where people come from. And so it's important to say, can we use this information not just at that time of care in the ER, but use it to extrapolate back to the communities that we want to try and provide benefit towards. So I presented these data a few years ago at the Mackinac Policy Conference. The Michigan Health Endowment Fund was there. That enabled us to get a grant of $500,000, which Wayne State matched. And we were able to build out Phoenix even further. Right? We were able to get data use agreements with a number of data partners. We have the medical systems, as I mentioned. We work now with MyHIN, the Michigan Health Information Network, trying to get a population health use case for all data on all patients in the state of Michigan. We work with the Poison Control Center. We have Poison Control Center data layered on top. We have medical examiner data. We have EMS data. We have data from companies like Loveland Technologies on tax liens, foreclosures, and evictions. We have Michigan Department of Corrections data. And what we're trying to do is pull all of these data points together so that we can understand geospatially and temporally what are the biological factors in a community that are contributing to differential outcomes, and what are the social factors that mediate or moderate those outcomes, put them all together in a cloud-based integrated program that we've set up through Google Cloud Platform on their program called BigQuery, and we can start to incorporate all of this information, again, so we can target outreach in communities. Google has a bunch of other data points that are already loaded in here, including American Community Survey, so it makes it a very facile way to pull in information. And there's also information available in Google on neighborhood assets. So if we identify a given census tract or a given community that has outlier risk, and we understand what some of the social variables are in those communities, we can include things like Google Places, right, and data from Google to understand what in given communities might be contributing to this. So not only what we see as factors, but where would we want to target interventions in that neighborhood, right? So you could see that there are a number of communities. We highlighted this one in the middle, 5369, number of communities where you have reduced assets, which make it less likely that, someone's going to get the care they need. We chose this community, just for an example, to look at high ER utilization of dental emergencies. So this community has more than 5% of all ER visits made for dental emergencies. Well, they don't have any dentists in the area. Maybe that leads people to go to the emergency department, and we could think about maybe doing outreach into that community to abort the need to go to the ER for dental cases just by incorporating this type of information. And this allows us to do other unique things, like not just look geospatially, but look at a concept of social spatially, if you will, something we call social tracks, taking this same information and understanding what confluence of determinants in a neighborhood might be contributing to outlier risk. And then when we go into those areas, we know that even though communities may be geographically non-proximate or disparate in terms of juxtaposition, they may be quite similar in terms of their social infrastructure that makes it more or less likely that these neighborhoods will have worse outcomes. Again, areas where you have less transit, fewer commerce opportunities, not a lot of physicians. You see a lot of those pockets across the cities of Detroit's 297 census tracts, and you clearly can understand why certain communities may or may not be higher risk, and you can have an understanding, a roadmap, if you will, about what might be needed in those given communities. And so that allows us then to take this, which is kind of a showstopper slide as far as I'm concerned, that my team pulled together from our Phoenix data, which shows differences in communities across Detroit and surrounding counties compared to the average life expectancy in the state of Michigan. So the average life expectancy in Michigan is 77.7 years. And what I had our team map out is communities where the average deviation was either lower or higher from that average. And you can see there are pockets across the city of Detroit where the average deviation is somewhere from 12 to 15 years younger than the national average, right? And if we know what's going on in those communities, we can then target and tailor community-based interventions for outreach that can address these problems. And it's quite shocking, right? You see just the border of Detroit and Dearborn over here, right? This community has a 9 to 13 year greater life expectancy. And on the border of that same geographically proximate area, you have an 8 to 12 year less life expectancy. So what can we do about that? How do we handle this? That's really the crux of everything that we're trying to do down here at Wayne State. Now, while we were building all of this out, COVID hit, right? And so we had this environment together to understand this and do outreach. And COVID really created a situation that can be best described through the lens of syndemics, where you have a disparity condition that promotes disease clustering. So if you take disease one, in this case being socioeconomic status as a backdrop, right, with high degree of cardiovascular risk, and you superimpose another condition on top of it, like COVID, you could certainly get an adverse interaction where you have enhanced disease transmission, progression, and negative health outcomes. And what did we see when COVID hit? We saw precisely that, right? We saw that in Detroit. This map was made on March 29th, 2020. We see in Detroit that you have an area around Sinai Grace Hospital that was really hard hit early on in terms of COVID cases and worst outcomes. Why was that? Well, they have a lot of older individuals in that area, age over 65 indicated by circles, populations over 65, a lot of nursing homes and homes for the aged and hospice residencies, but also a lot of social vulnerability. And so is it surprising that you have populations who are at risk when all of these things come together? And what we started to do around this is kind of accelerate our vision of what we wanted to do with Phoenix from the beginning, which is not just take data for data's sake, right? One of the things that my team has heard me say ad nauseum is that we don't need any more papers published that say it sucks to be poor and Black in urban America. We know this. What we need are solutions. We need ways that we can fix the problems. And so we'd always wanted to use the data for targeted outreach, and COVID enabled us to accelerate that vision. Here we are in Michigan. We partnered with the Ford Motor Company through a chance outreach to them. I was hooked up with the Ford X division because early on in the pandemic, we said we got to do something. We're seeing a large, number of deaths and cases in the city of Detroit. How do we get out and help our population? The first thing we did when COVID hit, we set up drive-through testing sites in Detroit at Wayne State Physician Group's headquarters, which is now known as Wayne Health, and at Access's headquarters in Dearborn. We have a very tight relationship with Access and work very closely with them. And at the time, we needed to get our firefighters back on the street. We needed our police officers back on the street. We needed ER doctors and nurses back in the hospital. So we set up healthcare provider and first responder testing sites in Detroit and Dearborn, but said, hey, if we're going to address this map, we have to get out into the community. So we partnered with the Ford Motor Company and started setting up mobile testing sites across the area using data to target and deploy our vehicles so we can reach communities that are hardest hit. And we said, all right, this is great, right? We're doing a lot of testing, reaching a lot of populations, but we still have the underlying risk that was there before, right? This concept of hypertension, right? And cardiovascular disease risk. And so we started overlaying COVID-19 prevalence data. And this map was from September 2020, right? A little while after we started moving things forward, where we could see, again, around Sinai Grace's neighborhood here, you have a high proportion of hypertension, a high density of COVID cases. So not just going out there and testing for COVID is going to be beneficial. It's not what these communities need. They need more. And we started morphing to this concept of what we call portable population health. So the Ford Motor Company was great in all of this. They sent their engineers, this is one of them, on site to understand the form and function of what we were doing. And we quickly moved to this concept of portable population health, where we said, we're going to be in a neighborhood. Why do we do just COVID swabs, right? We had started to do some antibody blood draws. The population wanted it. And we said, if we're going to stick a needle in someone's arm, in their car nonetheless, right? Why don't we measure things like lipids and hemoglobin A1Cs and comprehensive metabolic profiles? And why don't we start measuring blood pressures? And why don't we start screening for HIV and do other things? And why don't we start looking at vaccinations, which we knew were coming in September 2020, but not quite there yet? And beyond all of that, if we know that this is a highly vulnerable community, why don't we start incorporating patient navigators and community health workers and start understanding the social needs of the population we're trying to help so that we can address their problems immediately with things like fresh food and produce that we would give out on our sites, but also later through linkages to care, medically, or linkage to social service or food insecurity and ongoing support from there. And we built this out over time to where we now have a fleet of 10 of these upfitted vehicles, all of which have in-vehicle power upgrades with medical grade refrigeration. As you can see here, this is a centrifuge. We have upgraded power supplies. We draw blood. We spin it down. We put it in a refrigerator on site. And we've created a new way to think about how we can do population healthcare using geospatial analysis to target outreach into communities for COVID and beyond. Our work has been featured in several different things. Some of the work by the Duke Margolis Center and the Rockefeller Foundation, published work on hyperlocal COVID testing and vaccination strategies. There's some nice stuff in there talking about what we've done in Detroit, Michigan. We've also published on our work. We did a formative evaluation as we transitioned from pandemic response to portable population health. And using our data-driven deployment, which is really important, we went from testing about a quarter of the population that was from a socially vulnerable community to more than 40% of the population. So we were able to achieve our objectives of getting deep into communities that are at risk with social factors and then targeting the improvement in care for those populations. And as I said, we started out doing COVID diagnostic testing in March 2020, right? It became antibody testing, then we added HIV testing and all these other pieces over time. And where we're at now is we've had this program in place where we've now done almost 73,000 patient encounters. And as you can see here, it's been almost 52,000 unique patients with a mix of COVID testing, a lot of positive results, almost 9–10% over time, and a lot of COVID vaccination rates in communities that are difficult to reach. And if you look at our overall, reach of COVID tests administered, these are vaccinations administered, you can see that we've targeted areas with high social vulnerability, high COVID prevalence. What we also do is incorporate data from MICR, the state's immunization registry, that helps us understand where low vaccination rates are in communities, and we can target outreach to those communities, and we can track, did we make a difference in those populations? Same thing with COVID testing. We have a lot of areas where we've done a lot of testing that overlay with social vulnerability and high COVID prevalence. And so that's obviously really important. But when you look at what we started to do with social services, you really get at some of the needs assessment of the population. So starting through a relationship with Detroit Parent Network, and now ultimately building up a whole community health worker workforce that we bring on site to our program, we have a number of people who've received services. Almost 2,500 people who've requested social services have received them. And you can see it ranges from food assistance to public benefits assistance to unemployment assistance and navigator services, all the way down to PCP referral and all of these other things that we want to do. And so we've really changed the calibration and now have an ability to bring care directly into communities with our fleet of vehicles and steady funding to support this. As you can see here, we have a number of programs that we've done for linkage to care activity, but we've done a number of things as well, right? A number of HIV tests. We've added on hepatitis C testing as of late, and we've measured more than 3,000 blood pressures and done screening labs on almost 1,600 people. And when you look at these blood pressures that we've done, only 37% of them are normal. That means 53% of the population that we care for are going to fall into one or more hypertensive categories, right? And we have elevated blood pressure in about 10%, but stage 1 or stage 2 hypertension in more than 50% of the people that we screened in the community. And so now we're at the point where we've started to develop a whole dashboard around this. This only shows 903 blood pressure screenings, but you could see similar data as we start to pull this together, and this will allow us to really audit and understand what it is we're doing with our population. Really cool things have happened. Lead testing, we've done several hundred lead tests, and we are the state's only approved mobile lead testing program. And so our team is the one that's going out to Benton Harbor and doing lead testing on the population. Fortunately, none of the people that we've tested have met criteria for treatment for lead testing, and most of the results have been below 2, but obviously this is important outreach and population health information to do. The other thing, while I showed you data on the level of blood pressure elevation, we also have done about 1,600 people, as I said, lab tests, and almost 30% of all the lab tests that we've done have been abnormal. In particular, looking at EGFR for the Black population, almost 55% of all people who we do a comprehensive metabolic profile that's from the Black community is positive. Right. And so we're able to pick up on tremendous amounts of upstream risk that if we intervene now, that's what's going to enhance lifespan equality. Same thing with cholesterol, and hemoglobin A1Cs. And so we're really trying to move this needle and reimagine what healthcare looks like going forward. This is now our mobile health team. There's Chuck Shanley, who's the CEO and president of Wayne Health, and there I am. And what we've created is a website where people can go to request events. We have a calendar where people can see all the events that are occurring. If you click on a specific event, you can see all the services that are being provided. Very soon, people will be able to register and get everything they need right on the website in terms of care from these sites. But we haven't lost sight, like I said, from our basic concept that what we really need to do to move the needle on health outcomes and lifespan equality is, remember, cardiometabolic risk factor control during times of crisis and beyond. I think one of the most important things that COVID revealed is the fragility of our infrastructure for healthcare delivery, especially for vulnerable populations. And some of this is because of the risk that COVID itself brings, right? COVID, we know, exacerbated hypertension, inequalities in hypertension, inequities in hypertension control across the country. Some of this is due to the fact that people couldn't get into their doctor. Some of it's due to the fact that COVID itself impacts how blood pressure itself, right? Because it works through, the angiotensin 2 receptor and ACE2, right? It's a very important, confounder, if you will, on blood pressure control. And there's an evolving concept of coronavirus disease-related cardiometabolic syndrome, and trying to understand what was the substrate before this occurred, and then what was included or compounded on top of it by virtue of getting COVID. Things like biological determinants and social determinants coming together to produce baseline risk, and then superimposing COVID again in that syndemics concept, right, that increases risk. The other thing too, I alluded to this, access to care was really challenged during this period, and a lot of people who needed help with their chronic medical conditions couldn't get it. And so this is just some data from a publication in JAMA Open that looked at blood pressures being recorded prior to COVID, right? In primary care based offices, and then after COVID, and we see, early in COVID and later, a much greater decline in assessment of blood pressure and cholesterol. We saw much greater declines in visits for new treatments being initiated for hypertension, hyperlipidemia, and diabetes. And we also saw significant declines in total number of visits. Now, the solution in a lot of people's mind was remote care and telehealth, right? But we know that areas like Detroit, where we had the highest tertile of COVID test, COVID cases, had some of the lowest utilization of telehealth. And you can see this wasn't just unique to Detroit, but all over the country. There's a huge digital divide in the city of Detroit. There's inaccessibility of technology for a lot of the population. And so we can't expect one singular solution to be the answer to fill in the gap for other needs over time. So we started stepping back and saying, hey, we built this amazing machinery. What can we do now next going forward? Not just pandemic interrelated responsiveness, but going forward for the endemic component and for perpetuity. Can we think of this, right? These are maps that show blood pressure based on our Phoenix data, mapped out by census tract with social vulnerability. And can we target outreach into these communities with a lens of enhancing lifespan equality by getting upstream into the risk factor domain? And so we started conceptualizing this, and we're very fortunate to get a lot of funding that came in. We were part of NYU and University of Alabama, Birmingham's $20 million Health Equity Research Network submission to the American Heart Association with a proposal to prevent hypertension. We designed a program to use our mobile outreach to enhance access, targeting communities with geospatial analysis, and then giving people choices in what they want to do based on what we understand as risk factors in their own neighborhood. So we empower people through enhanced access and information to get linkages to the services we need, or they need, and use CHWs, not physicians or nurses necessarily, as the conduit to access those social determinants to be addressed. Things like care, transportation, food security, housing security, the things we were already doing with an aim of reducing blood pressure, and enhancing screening and enrollment, and then creating sustainable lifelong interventions that can help prevent someone from progressing from elevated blood pressure, which is above 120 but less than 130, so not meeting the diagnosis of hypertension, but also not meeting the definition of normal, and try to prevent those folks early on, right, from developing the risk factor, which is hypertension, and the consequences which come. We said, okay, this is terrific. We got this funding, maybe there's something here. And so we went next after a P50, an NIH chronic disease grant that intended on funding about 10 centers across the country with big projects to try to think about how we can reduce chronic disease disparities across the country. So we proposed this grant building upon our mechanism, and this grant called Achieve Greater, addressing cardiometabolic health inequities by early prevention in the Great Lakes region, has 3 projects which really try to flatten out, if you will, that steep trajectory that we saw before in terms of cardiovascular disease development and outcomes. Project 1 in Detroit and Project 2 in Detroit both use our mobile health unit programs. One focuses on people who have actual hypertension but low risk, stage 1. Project 2 focuses on people who have what's called stage A heart failure, which is essentially stage 2 hypertension or complicated stage 1 hypertension, meaning there's concurrent chronic kidney disease or diabetes. And then Project 3, which is based out of Cleveland, leverages a program that they've had in place to do free coronary artery calcium screening. We know that coronary heart disease is a big cause of preterm morbidity in a lot of communities, especially Cleveland and Detroit. And they've developed a program to do upfront screening, upstream screening for coronary heart disease using coronary artery calcium. And so the 3rd project in this really tries to improve equity and equality in lifespan by earlier emphasis on coronary heart risk. And the reason we chose Cleveland and matched it up with Detroit is because Cleveland has the same problem that we have in Detroit. I mean, a little bit worse with cancer, but has the same problem with heart disease and disproportionate death. And more importantly, Cleveland also has the same confluence of social factors that if we don't understand at a neighborhood by neighborhood level, we'll really not be able to address, what is driving these inequities in health outcome. So if you look at Detroit versus Cleveland versus the national average, right, you could see that children in poverty, income inequity scores, racial segregation scores, unemployment, violent crime, air pollution, lead risk, smoking. All of these things are such outliers. Physical inactivity and obesity and smoking, as we saw, are so critical, right, to lifespan inequality. Let's get things that can change that calibration by reaching out into communities and giving them choices. That's what the essence of what we're doing is, a program that enhances access, and then something called PAL squared, which is personalized, pragmatic, adaptable approaches to lifestyle and life circumstance intervention. And the latter portion, life circumstance, is something that often doesn't get tied into lifestyle, right? It's very easy as me as a doctor, when someone comes into my office or I see him in the ER, to say, hey, why don't you just exercise more? Why don't you just eat better? But if I don't know what their life circumstances are, that's a really hollow recommendation and perhaps a little uninformed and callous in the person I'm trying to help. So we use a RE-AIM framework, which is an implementation science framework to understand our reach, effectiveness, adoption, in implementation and maintenance. But what we're trying to do is change, adapt to a changing external conflict. We have this huge opportunity with COVID, right? It's an inflection point in history, in medical care. And if we don't think of new ways to reach people and we want to clamor back to the way things were, we're only going to have the same exact problems that we've had for forever, right? So increasing societal emphasis on prevention, we can capitalize on that for this new model. We can think of overarching risk factors and that may be going into how we interpret this, looking at internal context and looking at the different partners that we have in this whole equation. And a key point in all of this, again, is this PAL squared model, which involves community health workers who are working to improve access and linkage to care and address barriers to hypertension control, all in a way that can foster, better lifestyle intervention, things that can reduce this as allosteric, I apologize, I should say allostatic load, right? That compounded load of stress that people deal with that often, obviously is worse in communities of lower socioeconomic status. So that's where we're at and where things are going. This is our concept of what we're doing. This work is based out of iBio, which is right on Woodward next to the Amtrak station where I'm sitting right now. I know I threw a lot at you guys there. I really appreciate all the time that you took to listen to this. Sorry if I spoke a little bit fast. I am originally a New Yorker and still have my New York blood and have a lot to say sometimes in a short period of time. But just want to say it's really been a pleasure to put this together for you guys and to present this information. Then I welcome any questions and please feel free to reach out by email if anything comes up that you haven't addressed today. And again, thank you very much.
That was a fantastic presentation. And we do have a few questions, but I am going to start off with one of the comments. It says, this isn't a question per se, but a wow explanation regarding how you used the data you had captured to make a difference when the COVID outbreak began. Collecting blood samples and analyzing for other conditions like the hemoglobin AC for diabetes, HIV, offering fresh foods. It's all just amazing on how using data analysis is helping to make such a difference in health and potential outcomes. Thank you. We have another that says, thank you for this wonderful talk and for the amazing work that you're doing. Two questions. One, does your planning team include interdisciplinary representation from fields like communication to ensure effective messaging, as well as community leaders from the churches and other groups that would be trusted sources for both information and outreach? And there's a second part here. What are you doing in terms of follow-ups to help ensure compliance with treatment once health concerns are diagnosed?
Great. So I'll take the first one. So at this point now, we've done almost over 1,500 events with more than 250 different community partners. So we have an incredible network of community organizations that we work with on an ongoing basis. And the community organizations we work with, the specialty church groups, are the trust agency that we gain in the community. We never show up somewhere cold without knowing anything about what's occurring on the ground. And we rely on our community partners to help us understand where we want to go and how we should anticipate interacting with the population we're trying to help when we do go to a certain community. Some of the other things we do, though, is we not only work with community organizations, but we try to get our vehicles in the visual field of people in their neighborhoods on a regular basis. So we don't just go one day to a site. We often go several days in a row, and we go recurrently to sites over and over again. So when the Wayne Health mobile unit comes, people know they're there not to bill insurance and collect money off of them, because all the care we do is free. Everybody who comes, there's no appointments necessary. We don't require ID, but if it's available, we prefer it. We don't require insurance, but if it's available, we prefer it. I have philanthropic dollars that cover the cost of lab tests independent of this grant funding, and a lot of money from the state and other philanthropic agencies, like I said, that support the infrastructure for the mobile program. But the second question I think is really important. Once we identify people and capture them, so to say, with linkage, the way that we maintain ongoing continuity is two things. Number one, we have a program that we've built out of Wayne Health, which is a typical bricks and mortar concept, right? An office called the Center for Population Health Accountability, where we have individuals who are responsible for follow-up and ongoing communication with patients who are referred. So it's not like somebody gets a telephone number and everything's good, good luck figuring this out. Our navigators and community health workers on site schedule appointments, follow up with the person to make sure they have the transportation needs to get there. And then our providers work with the CHWs once somebody is seen to ensure that they have the support they need to get the resources they want and need for their care. And the model, though, that we're pushing going forward kind of flips all that on its head. What we're saying going forward is you only need to come interact with us in the field. So if we're sending 10 vehicles out each day and we have a calendar, those 10 vehicles are in 10 different locations across the region. Anybody who's being cared for as part of our grant work and ultimately part of our future vision can go to any one of our 10 mobile health unit sites. Whatever is most convenient to them. They can get all of their blood pressure measurement, lab work done right on site. And if they enroll in one of the studies, then they have a community health worker who's assigned to them. Not somebody who's just going to come and go, but this person is assigned to them to work with them over the course of the year, meeting with them at least monthly, if not more, right? Monthly after some things are stable, but on a regular basis. And we send all of them home with blood pressure cuffs and scales, again, paid for by the grant, but blood pressure cuffs and scales that have their own Wi-Fi signal that integrate data directly into our electronic health record. And so that's really important because this concept of remote patient monitoring today is really only designed as a reimbursable thing for Medicare, where people need to have at least 16 measurements a month in order to meet the checkbox for reimbursement. We're saying, well, what about the people who aren't Medicare and people who we just want to know, are you measuring your blood pressure and what is it? We're taking that and saying, forget this reimbursement mindset, right? It's not all about fee-for-service reimbursement. It's how do we get the care to the folks that we need, right? And so this type of remote monitoring that's not tied to reimbursement that the grants allow us to do is one thing. But where we're ultimately marching towards is a program of payment reform, where we can think of prevention services as a separate bin. And we can contract either with businesses or insurers, Medicaid MCOs, to do capitated prevention services that are completely separated from major medical or hospital care, right? Basically saying, how do we get care to individuals and take accountability for that in a prevention mindset? Really focusing on 20 to 50-year-olds, not that older individuals don't need care, but if you want to enhance lifespan equality, it's not going to be coming by throwing the kitchen sink at somebody as they're dying at 76. It's going to come by keeping them healthy when they're 40.
Thank you. Fantastic. We have another. Has there been any effort to screen the hypertension within the school systems?
Yes, so we work very closely with DPSCD, and we do our programs at DPSCD sites all across the city. Not only do we want to focus on potentially identifying pediatric hypertension, we want parents to come out too, because we understand that family units who all are working together on the health of the family is an important thing. People take cues from their parents, and parents nowadays take cues from their kids, right? And so we want to have that sort of family engagement around this concept. But absolutely, we see, getting even further upstream, right? Getting high school kids involved is important, but not only in terms of measuring blood pressure, but now we work with DPN, Detroit Parent Network, so that there are pipeline for kids in schools who want a career in this, that they can come to Wayne State, be trained as CHWs with us, get additional training going forward, right? So that they can become health coaches or nutritionists or whatever they want. But what we want are folks who look and sound like the people we're trying to help, right? And if we have a challenge reaching 20 to 25-year-old Black males, which we know Black male population is a huge population to target for prevention, it's not going to be me that's going to reach these folks. It's going to be people who look and sound like them and understand their lived experience. And so this connectivity to Detroit Public Schools is really critical going forward.
Thank you very much. Jennifer, do I see you have a question there? Okay, here's a question. Health coaches, you just mentioned that. Could you expound upon that a bit further? And the other thing was, you mentioned about remote monitoring.
Yep.
So what devices will people need within their homes to be able to use the remote monitoring process?
Yeah, I'll answer that second one first. So the short answer is it really depends on the company that you work with, right? So there are a number of devices available for this home remote monitoring. Some of them require a device that attaches to, something else that Bluetooths to a computer or your cell phone. Other devices, the ones that we specifically chose, don't require anything else. The devices themselves have built-in Wi-Fi technology. So all you need is a Wi-Fi enabled blood pressure cuff or scale, and that signal goes directly into the electronic health record. So once I give you that cuff, it's personalized for you. It's going to work forever, loading data into our EHR. We can control on our end the cellular signal that we're paying for to allow that information to be uploaded. And that's what our CHWs then use to do that remote monitoring. So, this will lead into kind of the second question is, what are health coaches? Health coaches are people who are trained to take information in and work with people to achieve goals, common goals, giving them the support they need to coach them through the process, if you will, right? I want to eat healthier. Well, here are some resources for you, but if you really want to, take it to the next level, we can help you understand how to shop. We can help you understand how to cook. And you coach the person through the process so that they get that strong connectivity and motivational interviewing that is needed to move things forward. Interestingly enough, one of the key components of all of this grant work is the CHWs and the trainings they receive. So typically when CHWs are used, they are trained by MSHWA. They get a certification through MSHWA, the Michigan Community Health Worker Association, but that's relatively limited in terms of its scope. So one of the things that we developed as part of this grant work is a whole set of additional trainings that are covered by the grant costs that work with our College of Education that are specific to hypertension and other risk factor knowledge, including specific training and motivational interviewing, so we can understand what the capacity and capabilities of our CHWs are by setting it up so that we train them. And then also we do ongoing what's called fidelity assessment. As part of implementation science, we track how well do the CHWs do what we taught them to do, right? Using standard patients, we can actually see, does a CHW effectively know how to do motivational interviewing? Are they incorporating it into their care plan when they interact with folks? And so we can have this continuous feedback loop. And then, like I said, a goal of this is that once people get motivated and excited to become community health workers, which is an $18 an hour paying job, right? Not a lot of money, but still better than nothing. We can get them additional training so that they can get higher and higher, income jobs. And, in that way, not only are we training people from the community to interact with the community, we're paying it forward to help address some of these income challenges by giving people upward mobility by adding additional training and education.
Thank you. We have another question here. You mentioned that you're also working on health financing reform that will allow you to transition away from grant funding. Are you meeting with receptivity or resistance from insurers on this? I
am meeting with a lot of receptivity, but I haven't gotten an agreement signed, if that's the way we want to think about it, right? We're very fortunate in the state. Many of us will remember Dr. Joni Caldoun, right? Was the medical director for the state, moved on now as chief health equity officer for CVS. CVS works with Aetna, works with some other aspects of the healthcare ecosystem. Inlets like that are helping to move this conversation forward. I've also been doing a lot of the rounds with our state senators and representatives, have a lot of support from the Detroit caucus, the Black Caucus, in Detroit, to help push the policy changes that are needed. Basically, what we really want in the future is to get away from the concept that the arbiter of health engagement is the work RVU, which is how doctors get paid nowadays, right? Do you have 15 or 30-minute encounters scheduled that you're seeing patients? Because I can't help someone in that 15-minute encounter with their social needs. I can identify them, but I can't help them. So if I tell you you're hypertensive and we get you on medication, but your real barrier to successful management of your blood pressure is food insecurity and housing insecurity, right? And you're so darn stressed by those things that no matter how many medications I give you, your blood pressure is not going to be controlled. Why keep coming back to me every 30 days to hear the same exact information? Why don't we flip the script, like I said, and make it so that a CHW can understand through a standard social determinant of health intake assessment, which we've incorporated, everything tied to specific action of ability for those social needs. Let's make that what we pay for. So can we go to insurers and say, instead of paying me $150 for every 15-minute encounter I do with this patient, why don't you give us $300 a month for these types of patients, and we'll figure out how to use that money to cover all the needs of that individual. And I can guarantee you the needs of that individual won't be coming back to the doctor's office every 30 days, right? What it will be is your CHW helping you get food service delivery, helping you get aligned with, housing authorities that can maybe help you with your tax lien, and then working with you to, understand exercise programs or things that you might want to do beyond. And again, thinking very differently about what goes into the box of healthcare, because the vast majority of the outcomes that we want to achieve are not impacted within the four walls of that encounter that currently occurs.
Thank you very much on that. We do have a stats question here, and I think you may have used it in some of your charts, your graphs. Explain the Pearson correlation coefficients.
I think that's a little bit beyond what we're talking about right here. But what you're trying to do is, use statistical methods to determine the relationship between factors, right? So the correlation coefficient, the higher the correlation, the closer you get to the number one, right? So 1 is a perfect correlation. That means that this is this every time, right? But we know the world's not perfect that way, and there's a lot of nuances. So a Pearson correlation coefficient, there are other, correlation coefficients out there, but it's just a way to measure that match between factors.
Thank you oh so much for this. There is one other question. Maybe in one of your charts, you had drugstore and you also had pharmacy. So what's the major difference there?
I think it's a matter of my computer science colleagues going in there and just kind of following what's listed in Google as opposed to combining them together. So again, that was meant to be exemplary, not definitive in terms of what it shows, but that's why that arises, because sometimes folks who look at computer screens all day and want to delve into healthcare don't always understand some of the nuances of that.
Very good then. This has been a wonderful, wonderful discussion. Let's see if I have another question that I haven't seen here. Oh, there's a comment. Your work is so impressive. Thank you.
Thank you so much. I appreciate, all the kind words and everything. And, what I talked to Edna and Jennifer about before, if anyone's listening now, later when this is recorded, if you're interested in doing work with us, please email me. We're very open to working with just about anybody and everybody, but we mostly want people who care, right? And who want to be part of this I wouldn't say social experiment, because it's far beyond that, right? This is really about how do we institute substantive change in the way we think of health outcomes and healthcare delivery. And again, my biggest thing in all of this is we have an inflection point in time that COVID has brought upon us. Let's not use it as a way to try to adhere to the way things were, because they were pretty bad before, right? So I don't know what all of us may be feeling, sort of yearning or nostalgia for the way healthcare used to be, right? But going forward, we have an opportunity to reimagine healthcare. We have an opportunity to take the lessons of COVID, which basically were, you can't go to your doctor for a test. You can't go to your doctor for a vaccine. You got to fend for yourself. So you know what? People have learned to fend for themselves a little bit. Let's give them the support they need, remove barriers, and be partners in their healthcare journey.
we have one more comment. Thank you so much for this presentation. The innovation and passion of your team is very inspiring. And with that comment, it could be the ending comments for our session today, for our lecture today. This has been wonderful. Thank you for the presentation. Thank you for your generosity in offering your slides that we could look at later. And if there are further questions that you would be willing to entertain, could we pass on your contact information?
Yep. Yeah, it was the last slide in the presentation, but it's PLEVY at med.wayne, WAYNE.edu. And Alan, no last name, but asked how people can get involved in this. Email me. And what I'll likely do is link you up with another member of my team. I have, as you can see in that picture, a lot of people who are now working as part of this, and a lot of people who are continuing to work as part of this because they're inspired by the mission, right? We have a lot of nurses who left their prior healthcare jobs because they didn't really feel like they could be nurses, who've now come to work with us because we give them a chance to really work with people and be what they've always wanted to be in terms of healthcare professions. So please email. I'll link you up with the right people. And just to say this too, we appreciate volunteers, but we also understand volunteerism only goes so far, and we're very well funded. So we're happy to look at ways to bring people on as casual or full-time employees if that's of interest to anybody. I know that this is a community that may have had jobs previously and aren't so interested at this point, but we're happy to work with you to figure out any way to get you guys involved if your heart's in that place.
Okay, I think you just answered. What is your preferred way to be reached, that we could reach out? And Jennifer has put your email into the chat. So if people are interested, for those who would like to be able to reach you at some later time, please check the chat. Jennifer has loaded that. Thank you, thank you, thank you. And I guess I had one more in the coaches, and you were saying, could younger people like in high school seniors or something, could that be a project that they could take on to help with grandparents or something like that?
Absolutely. Absolutely. I mean, if there are kids who want to get involved in this, we can hook them up with the College of Education right here at Wayne State. They have a great health coaching program, but absolutely, these are skills that you can use the rest of your life in various ways, even if you're going to go ultimately into the medical profession, nursing, pharmacist, physician, whatever you're going to go for your training. This type of concept is going to be with you your whole career, right? What we're really trying to drive is a team-based approach to healthcare where, let's figure out what the needs of the person are and deliver on those needs and not just say this is the one way you get care.
Thank you, thank you, thank you. We've kept you a little bit over time, but we appreciate your time. And for those of you who have joined us today, thank you for your participation. Thank you for joining us. Thank you for the wonderful comments and the questions that you've had. Our next sessions will be starting the March. So please check into Ollie for the schedule. Thank you again. And everybody have a wonderful rest of your week. Bye. Thanks, now.
Bye.